Thank you so much for coming today. My aim on social was to try to get women of all ages to show up because this topic really impacts all ages. And I'll introduce myself right away, but I work with women in naturopathic. I'm a naturopathic physician and researcher, and I work with women of all ages. And I just moved here from the West Coast, from Portland, Oregon. Just opened my practice here 2.5 or almost 3 months ago. And it's a joy to be here. I love this area. The clinic that I was working at on the West Coast, it was a menopause-specific clinic. So I'll call it a woman's time and menopause options. Because we had practitioners of all ages and interests in the clinic, I also focused on fertility care, and I have a very, very big passion for hormones. So hormones are that's my thing. I'm really interested in the hormone intersection between gut health, brain health, and hormonal health. But women, mostly in their menopausal years, would come into our clinic, and so that was really our main focus in the clinic. We were menopause-specific practitioners trained as menopause care doctors, and so it's different when you have a menopause very much trained and focused doctor to work with. So we just tend to be a little bit more acutely aware of all the changes that happen. But I did have quite a few women, younger women, who were going through menopause, early menopause, premature ovarian insufficiency that I was treating even in their teens. So my goal online was to say, look, let's have more of a big conversation about this, try to normalize the conversation because it is so important. So we'll go ahead and get started. And I am going to put you to work because that's what I do. I do teach in university settings. I teach medical students of all different backgrounds. And I usually put people to work because I want them to be very engaged. So I am going to put you to work in just a minute. So here's my background. I actually went to Smith College, so I have a little bit of experience living on the East Coast. Went back to the West Coast and then did my naturopathic degree there. Spent about 8 years doing that, plus my postgraduate training and my residency. I did a very intensive focus in women's health during my training, mentorship, and then postgraduate study underneath Tori Hudson, who in our world of naturopathic medicine, she's like the Christine Northrup of naturopathic medicine. So it was an honor to work with her, and she's a very close friend and colleague now. And she was right across the hall, so anything that was really tricky or challenging, just pull her right into my visits, say, Tori, what do you think? Come look at this. We did it back and forth too. So she would send me her most difficult fertility cases, and I would have her come in to some of my more difficult or kind of complex or complicated overall hormone cases. During her residency that I was under her wing, I shadowed MDs. I shadowed reproductive endocrinologists mostly, but endocrinology of all different backgrounds. Even studied with a pediatric endocrinologist who did focus on trans care for peds, which was really quite unusual, I would say, to have a peds-specific MD who is focused in that community. But it was really great because I saw hormone care of all different types, and have really great colleagues now that I can just call in an instant and say, this is a complicated case, what should we do? What should I do? So here now, I'm just building my relationships with docs. I was on the phone with a few MDs today just saying, hi, nice to meet you. I'd love to take you out to coffee, tea. Anyway, getting started, but I've been very excited to see that it's been a really warm welcome. And I feel like I'm going to be able to work well with the practitioners here in the community. So I am also a researcher, did a postgraduate research fellowship, and all the topics really in women's health. So specifically HPV-related cervical dysplasia, infertility, and interstitial cystitis. Those have been areas of focus. And I'm looking at also intuitive eating for women who have hypothalamic amenorrhea, which is a condition that is a suppression of brain hormones, basically, that causes a lack of menses. And we're looking to see if we can treat it through more expansive eating styles. All right, just gonna pass out a few more papers. And by the way, hi, thank you so much for coming. Please interrupt and ask questions. We can also save it to the end, however you'd like to do it. And then also, I'm really practicing speaking to the general public, kind of more like breaking down complex topics in a simple and easy to understand way. But I do speak to medical doctors and train medical doctors on these topics too. So I hope if I say something that's too complex, just say, Dr. Dunlap, stop, wait, hold on, I don't get it. Do not feel bad about asking me to repeat or explain, and just kind of slow it down. Well, and then I'm trying to also just give you the real science too behind it. So today we're going to talk about what is happening, how can I tell if it's happening to me, what are my options in preparation and during this transition, which is totally part of our natural life. Like this is not a condition, it's not a disease, right? This is part of what we're all going through. And how do we prepare and be strong through this transition so we can mature as gracefully as possible. And then I'm going to talk about pros and cons of bioidentical hormone therapy, because that's on a lot of women's minds. And I'm going to go through the risks, the research, and I want you to feel informed. And this is where really being a menopause specific trained doctor has really helped me in my practice. And I've treated a ton of women with bioidentical hormones, and really they can be very helpful in the right circumstances and in the right way. And I'll talk to you all about that, so that you feel like whoever you're working with, you have some education that you can bring to the table. And then of course, stop me and ask anytime. Okay, so we're gonna go back to this. So you see where we're going right now, right? Okay, so what do you remember about the menstrual cycle? What do you know about a menstrual cycle? So what I would like for you to do is take your pad of paper, and don't feel embarrassed, because I ask medical students to do this and they don't remember anything. So they do not remember anything. So what I'd like for you to do is, on this pad of paper, I just want you to draw a graph. And this is, let's say, day 1 and day 28 here, okay? And I want you to, we have 4 hormones we're gonna mostly talk about today. What I really want you to think about are estrogen and progesterone, because those are the main hormones that we really feel impacted by in this transition. So throughout this, let's say day 1 is the first day we bleed, okay? And day 28, that's kind of your classic cycle length. So what's happening with those hormones from day 1 to day 28, if you remember? And do you remember also when you ovulate, or when you would ovulate and at what day? And if you don't remember anything, just totally fine. Just don't write anything, or you can just play around, and we're about to go over that, because that's key in understanding what's happening during this time. Do you want me to give you a piece of paper and a pen? Oh. A little pop quiz. Nobody's judging you, by the way. I do this with medical students who are researchers, who have done all their pre-med, pre-recs, and they're new students, and they get freaked out because they don't want anybody seeing their paper. But it's a good exercise, because it's amazing, actually. As women, we go through this, and we experience menses, but most of us know so little actually about, or it's complicated. So it's not our fault. It's complicated. Okay, so just progesterone and estrogen, what do you remember? And ovulation, when does that occur? Okay, so no shame in not knowing or not remembering, because this is tough. And I review this all the time still, even just like the very details. And I have it memorized, but I also I'm constantly looking at the graphs and analyzing, because it really helps me explain to women what's happening in their bodies. So basically day 1 to day 28, here we see the 4 different hormones that we're going to talk about: progesterone, estrogen, LH, and FSH. Our brain is communicating with our ovaries, and they have to be communicating in order for us to experience any sort of menstrual cycle. So the hypothalamus and the pituitary of our brain are communicating with the ovaries. LH and FSH coming from the brain, talking to those ovaries, which produce estrogen and progesterone. So throughout a cycle, a 28-day cycle, we have this growing follicle in blue here. It grows bigger and bigger. We actually have multiple, and they're all kind of competing to be the one to release an egg. We're born with so many of those follicles available, eggs available. And every year, our body's recruiting a good handful to become the one about a year later to release an egg. A lot of those are lost to what we call atresia, or they just kind of disintegrate. But there's one that kind of produces or ovulates and produces the egg, and that's called the Graafian follicle. It's like the one that got to the end, basically. So that Graafian follicle matures, and about day 14 releases an egg. The remaining cyst, so in yellow you see the remaining cyst that's left over after the egg leaves, it's like a cyst. And cysts can be good, they're just part of normal biology. That remaining cyst is a progesterone producing machine. So when we don't ovulate, we have very little progesterone, very little. And that's where a lot of the symptoms start with menopause. And I'm going to talk about that. What's happening with our hormones, if we are ovulating, we are releasing an egg, at the beginning we have low hormones. That's like when our hormones are in the tank, is when we're bleeding, okay? That's when a lot of women start feeling PMS symptoms, when the hormones start tanking. And that's right before and then during bleeding. That's why we bleed. We actually bleed because we have low hormone. And then our estrogen starts to build up in red. And then you see this big spike in the middle, and that big spike is LH. LH goes really high, and if you ever use an ovulator predictor kit, it's actually luteinizing hormone predictor kit. That's a lot of infertility. We recommend women using those to predict when they're ovulating. That goes really high right before the corpus luteum releases that egg. And then that progesterone producing cyst that's left over produces progesterone, as you see in yellow. Estrogen kind of goes down and then it goes back up a little bit. But really, the end part of our cycle is all about progesterone. And progesterone, what progesterone does, and I'm going to explain both, but I think about estrogen as like laying the bricks. Estrogen is a bricklayer. Estrogen builds up the lining in our uterus. It does a lot of other things in our body too. Progesterone comes in and it's like the mortar between the bricks. It helps keep everything nice and firm and healthy, and it helps these little spiral arteries come in through the tissue to feed if an egg or if a blastocyst or an embryo implants into that lining, it can feed that growing embryo. So that's progesterone's job, is to make it nice and soft and hospitable. The body temperature goes up during the second half of the cycle. But as we age and we have less eggs, you missed our fun little exercise where I had everybody draw the menstrual cycle. No, it's okay. As we age and we stop having eggs to release, we're not producing that progesterone in the luteal phase, and we start feeling unlike ourselves. We really start feeling irritable, moody, PMS symptoms like crazy, and all sorts of other things that come along with low progesterone. Okay, and I'm going to explain more. I'm going to repeat. But again, tell me if you feel like I'm not explaining well enough. Okay, so again, here's just what we just talked about. That day 1 to 5, we're bleeding. That's our period. I'm just going over this to give you the ground, laying the foundation. Day 4 to 15, that's when the uterine lining, so this is the lining here. And it's the uterine lining starting to build up, estrogen's going up, and then at that day 14, typically, some people are early, some people are late, is when the ovulation occurs. The LH goes way up. And then the secretory phase, or the luteal phase, the second half of the cycle, the spiral arteries start to elongate, become more abundant, and that's when progesterone is really feeding that tissue of the uterine lining, making a nice soft bed for what it's hoping will be an embryo that implants there. And then when nothing happens, then both of those hormones start to drop, and they drop, and then this lining sheds, and that's the menses. Okay, so that is the groundwork for what is, 20 to 40 years old, typically normal menstrual cycle. So what is menopause? Menopause is actually only a 24-hour period. Menopause, as a term, is only a 24-hour period. It's a whole year past the last menstrual cycle that we've had. So we have to go a whole year before we even get that term menopause. Anything before that, when we're experiencing symptoms, is peri. And perimenopause can last 10 years plus. It is the most unnerving thing to start having symptoms early on in life. And you're like, I'm not ready for this. This is not, and I have women all the time come in and say, is this really happening? Because I feel like I'm too young, and they might be in their 30s, or like I hear their symptoms, and I'm just like, I think yes, you're early, but I think we have to investigate this. And then some women, they don't experience anything till their mid-50s. So it's just really across the board. It has a lot to do with genetics. It has a lot to do with lifestyle, and I'll explain that. So peri is really the bulk of the time before menopause, and then menopause is that 1 year, one day, that's a year after the last menstrual cycle. And then post is everything after that. When we talk about climacteric, those are the symptoms that accompany peri, menopause, and postmenopause. Those are the symptoms. And I wrote here that it can occur 2 to 3 years before and 2 to 5 years after, but in some women, it's like half of their life. It is not fair, and it is not what they did to themselves. It doesn't mean that they, it can be very genetic, is what I'm saying. It can be very genetic, and I just do my best to help normalize for women as they come in and say, what's wrong with me? and I do my best to, I treat, and help women transition all the time, and there's so much we can do to make this easier. So this is our ovary. I just wanted to show you here with those primordial, those little cysts. Those are what we're born with. We're born with over 2 million. By the time we actually have a period at menarche, we have less than 1 million. So they disintegrate on their own, and then they disintegrate through our whole lifetime without even releasing an egg. So, and then they go through this phase of maturing until you get to that Graafian follicle, like I was explaining, and that releases an egg. And that maturation period takes a whole year, while they're kind of competing. And this is just kind of, it shows the follicle number when we're born, and then how we have less as we age. And that is part of our transition. That's part of normal physiology. It's not a condition or not a disease. It's just the more we talk about it, and the more we talk about it, I think at a young age, hopefully the more normalized we can make this, because I feel like the more women know, the more they can prepare and kind of not be taken by surprise in their symptoms. And this is an ultrasound looking at the ovary. So the ovary is outlined about here. And you can see the little black vacuoles. Those are the cysts that are maturing. We call this an antral-follicle count when we count those cysts. And this is kind of what we consider maybe normal within like a 30-year-old. What 30-year-olds can have premature ovarian insufficiency. But this would be, let's say, we have like 10 antral-follicle count here. And this would be where you don't see anything here. So you see the outline of the ovary, but we don't see any follicles. And this is what's happening in our kind of lab work. So in the body, we have these feedback loops. And from the brain to the ovaries, we have that FSH and LH. The FSH and LH are telling the ovaries to grow those follicles, to mature those follicles so that we can release an egg. When we have less follicles to mature, those hormones from the brain increase. They're kind of yelling at the body, like, make more, I need more. I notice that I'm having less estrogen, less progesterone, because the estrogen and progesterone go back up to the brain and give the signal to make more FSH, LH, or less FSH and LH. Does that make sense? It's called a feedback loop. So we have it's called negative and positive. We have, those conditions can actually produce their own hormones. So it actually kind of is a false, delayed menopause. So it's not always a good thing to go late. Sometimes when I see somebody hasn't gone through, haven't reached the menopause timeline yet, I do check for those. I'll do a pelvic ultrasound because I want to make sure I'm not missing anything. And if they have abnormal bleeding or really heavy bleeding, which can be very normal when we're having irregular cycles, I do often do a biopsy of the uterine tissue, the lining, because I want to make sure I'm not missing any abnormal cells. That would show up. That's what we do as our first line workup for any uterine precancer. Early menopause can be totally genetic. It can be due to autoimmune disease. radiation and chemo, chronic disease such as tuberculosis, surgeries, if you've had a hysterectomy and have even a hysterectomy alone without the ovaries removed can hasten menopause. And it has to do with this communication, I think, between the uterus and the ovaries. But often women will go into perimenopausal symptoms early, even if they have their ovaries. So I always watch out for that. But yeah, certainly if the ovaries are removed, even one, or, they're gonna most likely experience more symptoms and go hasten their timeline. Certain drugs can certainly push this. Corticosteroids used over a long period of time, even Clomid used over a long period of time. That's when most doctors who prescribe Clomid will only prescribe it for a certain period of time. Also some lifestyle choices, rock and roll lifestyle. Rock and roll lifestyle will hasten menopause. So I'll have women who want to get pregnant at 40, and if they've had a rock and roll lifestyle, I'm really anticipating I'm going to see labs that aren't favorable. Yes. Oh, gotcha. So actually, I can see labs kind of reverse. Once the eggs have this kind of atresia, we call it, where they've kind of, they've gone. Once that's happened, we can't get them back. But sometimes those labs do fluctuate. So I don't make any premature diagnosis unless I've seen multiple labs, and I always repeat them, and counseling on how to change lifestyle, diet, that sort of thing, to help not only decrease symptoms, but help kind of not hasten the process, I guess. Although sometimes we might want to hasten it. We might want to, because it's so dragged out. Okay, so here's what I was explaining before: the brain and the pituitary, and then the ovaries. So our hypothalamus and our pituitary making FSH and LH, and then those ovaries are making the estrogen and progesterone, which then act on the uterus. And then they go back up to the brain and say, either I need more or I need less, okay? So that's how the body is constantly communicating. Hormones are fascinating because hormones are basically any chemical signal that goes from one organ to another in the body. And it can happen from our adrenals, our pancreas, our brain, our ovaries, for men, testes. It's fascinating to me. And thyroid, of course, thyroid. Okay, so these are the hormones I was talking about. I already kind of explained what they do, but again, estrogen stimulating the lining to build up, but it feeds all tissues. So I think about estrogen, it's thickening the lining of the uterus, but it's doing that in all of our kind of skin, arteries, all over the body. And then progesterone's helping maintain the thickness of the blood vessels to support. So what is actually happening? So during this climacteric period, the ovary activity is declining. Initially, the ovulation isn't happening. Initially, we're starting to have irregular ovulation. So irregular ovulation happens when we start our period until about age 16, typically, or 18. Often we'll have anovulatory, what we call anovulatory or non-ovulating cycles. So we get all these kind of random bleeding patterns. And the same thing happens after 40. We start to have anovulatory cycles. So ovarian activity is declining. We're not producing that progesterone that makes us feel calm, helps us sleep, makes us feel stable in our mood. That Graafian follicle later starts not to develop because we don't have the eggs to create it. And so then estrogen is not being, it's the development of that follicle that's producing the estrogen. So over that whole year, as all those follicles are developing, they are producing estrogen. And it's that follicle that remains, or that cyst that remains after ovulation, that's producing the progesterone. So then the FSH and LH go up, and we test FSH and we say, where are we at here? Are we, early perimenopause, late perimenopause, close to menopause? Where are we? And then I kind of explained this already, but FSH can basically go up as much as 50 times. So if we see an FSH below 10, these are the numbers, but I'm like, okay, you're very, you still get pregnant, 20 to 30 less likely, 30 and above, especially multiple times testing that FSH. much less likely. And, if we're getting 30 and above, and I've repeated it multiple times, and we're seeing other symptoms too, perimenopause, that's perimenopause. But it's really not a diagnosis that's given on labs. Often doctors won't even test the labs because it's like, you have the symptoms, you're at that age, we're all gonna go through it. This is what's happening. And plus, the frustrating thing about the lab test, it's not gonna tell us when it's over. It's like, there's no predictor. And we actually, in the research, we're starting to do some research on using FSH and AMH, which is another test, to see if we can kind of figure out exactly the timeline to help predict. But there's no predictor test now. And this graph is basically showing that progesterone is declining first. So in the age range here, progesterone declines first, and then we see the decline of estrogen later. And this is just another graph to show that estrogen and progesterone goes down first, then estrogen, and as that happens, the FSH and LH are going up. So a few ways to kind of understand it. The estrogen is the pink. It's just the spelling, yeah. It's like the European spelling. So what are the symptoms? They're all over the board. We get so many, it's like the perfect storm, especially when we're trying to deal with the transition. We're trying to prepare ourselves for this change that's going to happen to all of us. I say, like, we're either going to die young or we keep getting older. It's like, there's no choice. This is like, you're going to have to push that baby out one way or another. It's the same thing. We're going to have to go through this transition one way or another. It's not easy and it's not fun, but the symptoms then make it adds insult to the situation where we're dealing with these symptoms, and they're so common. I mean, 80% of women have symptoms. So we're experiencing this together, and the more we can normalize the conversation, the more talk about it, I think the better. Hot flashes, night sweats, huge. 80% of women are gonna have those, especially as they get closer to that menopause specific time. Irregular vaginal bleeding or no bleeding at all, vaginal dryness, itching, irritation, pain with sex, prone towards infection. So common and so easy to treat. Do not be afraid to bring this up with your doctor. I'm having trouble having sex. It's just not pleasurable. I'm having this irritation. I'm having more UTIs. This is very common, and it's really quite easy to treat. And I'm going to explain the treatment after in a little bit. Fatigue, memory problems, irritability, that usually occurs with that dropping progesterone. So that happens really fast. You notice yourself just like quick to react, not your normal self, just quick to tears, so common. Weight gain, typically like around 5 pounds. That's the average weight gain, especially around the abdomen. Acne can occur because of the changes in testosterone too. Hair growth on the face, that's that kind of coarse hair growth. Bone loss, osteoporosis, because estrogen actually feeds the growth of the bones. So it actually feeds what we call the osteoblasts, the little osteoblasts, little cells that are building the bone, feeds that bone development. And when we have less estrogen, we're having less bone development, but we're still having the bone turnover. It's always, those cells are always turning over. We're having more turnover than we are of the baby cells growing into new bones. Cardiovascular changes occur, and then diminished sexual well-being, which can include decreased interest, decreased libido, decreased arousal, and then just like I was explaining, that kind of dryness, itching, irritation. That I treat that all the time, very successfully, and that can just diminish our interest too, just because it's like not fun, And regardless if we're women with women, women with men, it's like the same, because it's not fun. It just doesn't feel like, we don't feel like our healthy selves down there. And this is, yeah, go ahead, please. Yeah, so typically we just have changes in the way that our free testosterone. We have kind of erratic free testosterone. Free testosterone creates more of it can create male pattern balding. So we see hair changes, hair loss, acne, where we okay, I'm back to being a teenager. I feel like this is ridiculous. That happens. And then the hair growth. So it's this free testosterone that changes as our other hormones are dropping. Because estrogen it's kind of complex, but basically estrogen creates more of a holding ground for that free testosterone. And as our estrogen is dropping, that free testosterone is kind of like a loose cannon. So here's like a graphic on what each hormone specifically makes us feel. So estrogen, too little estrogen can create brain fog, depression, blue, feeling blue, headaches. We see that. I see that also. Too little progesterone, that's the irritability, anxiety, insomnia piece. When women are not sleeping, when anyone's not sleeping, it's a disaster, right? It's like a complete disaster. We don't feel like ourselves if we're just not sleeping. So one of my goals with women is like, let's get you sleeping. Like, let's get you sleeping. Then we can work on all aspects of health much more easily. Irritability, too much testosterone, because it's like that free testosterone I was explaining can lead to that acne and oily skin, hair loss, sleep problems too. Too much or too little cortisol. And this is where I feel like so many women moving into this transition, if we talk about it more, we can prepare better. This is like our threshold for dealing with stress as we age lowers. So we have to take much better care of ourselves, like going to bed at a good hour. We can't do as much of the party lifestyle. Our bodies are just much more sensitive to all of it. And we're much more easy to notice the symptoms right away. So taking care of that cortisol, taking care of the body before we get to this stage is so important. And then during, so we can make sure we're feeling good. And then too little thyroid can create brain fog, muscle aches, hair loss, dry skin. Thyroid is huge. Thyroid goes way underdiagnosed. Hypo or underfunctioning thyroid goes way underdiagnosed. And thyroid conditions really start to pop up in perimenopause a lot. So I'm constantly working on thyroid with my women too. So what causes hot flashes? It's that fluctuating estrogen level, the fluctuating estrogen levels, and how those estrogen levels actually interplay with our epinephrine and our cortisol. So like our stress hormones, and then how that impacts the brain and our neurotransmitters. So neurotransmitters specifically here is serotonin. Serotonin has an impact on our thermoregulatory system. So it's the drop in estrogen that then creates this release of norepinephrine and serotonin that's like a roller coaster, and it creates a dysfunctional thermoregulatory system. So we're having these like inappropriate heat, we have what's called an inappropriate heat loss mechanism, but it's just our bodies getting used to a new normal. And it's when we're going through perimenopause, our hormones are doing this every day, like way erratic. So it's not that picture of like the cycle of a 20 to 40-year-old typical, right? It's like this. Our hormones are doing this every single day. So it's very tricky, honestly, to test hormones when we're perimenopausal. There are ways to do it, but this is the normal, and things are kind of doing this as they're decreasing. And it's that up and down the body has such trouble with, and that creates the hot flash symptom. And eventually we get to the steady state. That's a lower level of hormone, but we still have it. And our body takes over in other ways, and I'll explain how. But that's when we start to feel, okay, less hot flashes, less night sweats. But some women, it goes on. It does go on, and it's a quality of life question. How do we treat? There are great ways to treat. So libido can, so it's the decline eventually. So testosterone is eventually declining too, and estrogen, but it can lead to atrophying of the urogenital tissue. Basically, things kind of shrink, they dry, the skin becomes thinner, and this can just lead to less ability to become aroused. But there are ways to help with that. And I always want women to know, like, you do not need to stop having a good sex life. Like, you can, keep that tissue nice and healthy. And it's not, we don't have to just stop enjoying that part of our life. But there can be other reasons too. And so we want to make sure there's not an infection, because we're more prone to infection. And it has to do with the way the vaginal microbiome or the microorganisms in the vagina change over time with that decreasing estrogen. But we can treat it. And now we're living longer, and it's like treating, I think, it's a quality of life. It's a prevention method. I've really a pro treatment of the vaginal tissue. Like, let's keep the vagina really happy because our women are going to be much happier. Excuse me, getting over a cold. Vaginas need to be happy. So other things to consider, and this is all just like, the more we're empowered with, this can feel like depressing, but at the same time, the more we're empowered with the information, the more we can do to soften the transition, to ease the transition, to make ourselves feel strong through it, because there is a lot of good that comes too. There's like we lower our threshold with dealing with shit too, I tell you that. Women come in, we draw back this curtain, we have to focus on what hasn't worked in our life so far. We have to make big changes. A lot of women make big changes at this time of their life. A lot of women are producing their life's work around this time. There's let's get this done. I'm not going to put up with the bullshit anymore kind of thing. And it's really beautiful. And the more we can like step in, I mean, I just tested, I know I'm in there with you guys. I just got my labs back. But we're all going there. We're all transitioning. So the more I think we can make less social stigma around it, and really, I'm trying to do it too, like, it's hard. We're all dealing. Okay, osteoporosis. We begin to decline by age 40 in terms of our bone health. And it's accelerated by menopause because that estrogen's dropping, is not feeding the bone tissue to grow. And then 1 in 2 women are going to have osteoporosis or osteopenia in their later years, 1 in 2. And then if we're going to talk about the risk factors, but basically thin, long and lean, family history puts us at greater risk for bone loss. If there's any steroid use over our lifetime, any gut dysfunction, we're at higher risk. Any sort of like eating disorder, we're at higher risk. Malabsorption of the gut, of the minerals, we're at higher risk. Sedentary lifestyle, we're at higher risk. And then, the increased risk of falls later in life. I'm always thinking ahead, because that with anyone, a risk of fall means more sedentary living, and health can change quickly after that. So I don't want people to have breaks. I'm very motivated for that. Cardiovascular disease risk. So before menopause, women generally have less cardiovascular disease risk, including stroke, all sorts of cardiovascular disease. We're talking about cholesterol, we're talking about heart attacks, we're talking about stroke, we're talking about blood clots. We have less risk than men before menopause. After menopause, that switches. And so it's the decline of the estrogen. This is what we theorize in medicine. It's the decline of the estrogen that leads to these stiffer arteries that puts us at higher risk. It changes the way our cholesterol is. Cholesterol can go up. Estrogen is very cardioprotective. It's like an antioxidant. So it's a good thing. Oftentimes, I think estrogen gets a bad rap. It's like, we don't want to be estrogen dominant. You hear that a lot. But actually, we want to have enough estrogen. And we can naturally have enough estrogen without taking hormones. But we have to take good care of ourselves, too. So we talked about the cholesterol piece. Like I said, just stop me anytime. This is one that's tough. This is tough. Skin changes. So collagen's reduced because estrogen's feeding the collagen, and we start to see the thinning and the wrinkling. And that accelerates quite quickly after menopause. So we see about 30% of the skin collagen lost after those first 5 years, and then 2% per year after that. So it kind of slows down after that, but it's that really like that time right after that it goes quickly. And this is where there are a lot of ways to work with this, but we have to be much kinder to our skin. We can't push it. We can't stay up late. There's so much to do to take care of the body, but it's like we have just a lower threshold for everything just this time. Central nervous system changes. There's such a thing as menopause brain. It's real because estrogen feeds the brain. Estrogen increases cerebral blood flow. It helps with the neuronal connections. It helps us with cognition and memory. And synaptic activity. So when estrogen is dropping, we feel like we cannot think, we cannot remember, we have short-term memory loss. Those are all very common signs that something's happening, but that can also be with thyroid. So I always look at thyroid too with that. And it can be with also vitamin deficiencies. So I see that all the time too, B12 especially. And if there's a long history or if we've been indulging in a little too much alcohol, alcohol will deplete B12 like crazy. B12 really helps with neuronal connections and cognition too. So B12 is a great thing to use for women who are low. So what kind of testing might we do? So this is what I do in my practice. I'm looking at general wellness exam, making sure that PAP is done, making sure there's no changes there that need attention, looking at the tissues, seeing, a lot of times women are like, everything's fine down there. But when I look, it seems like things are getting thinner. It's looking redder, a little irritable. And I know what's coming is that what happens is the urethra, where the urine comes out, is basically at an angle like this during our lifetime. But when that tissue thins, it becomes more horizontal. It kind of, like everything in the body kind of droops a little bit. Same thing's happening down there. And it makes it more easy. And then the tissue around the end of it starts to thin. And so it makes it easier for bacteria to ascend. So we have more risk for UTIs. And as estrogen's dropping, there's less lactobacilli in the vaginal vault. And that lactobacilli keep it nice and acidic. We actually want a acidic vaginal vault. And we're more at risk for BV, which is you can like have that amine odor, it's like a fishy odor or irritation. It doesn't feel good. Like penetration it just doesn't feel good down there. And that is very easily treatable. So I'll talk to you about that too. Estrogen, FSH, LH, those are some labs to consider. Definitely a bone density test at this time of our life is worth asking for. See if your doctor is willing to order it. If this is something you think you might want them to explore, because if you have osteopenia or osteoporosis and you're wanting to consider bioidentical hormone therapy, and I'm a fan of bioidentical hormone therapy when needed, that test can help get you prescribed. So, and I'll explain what will constitute prescribing. Okay, and I'll explain there are ways you don't have to go through this. You don't have to have hormone therapy. I'll explain that. But in the case that it's helpful for you and it's a quality of life consideration and it can really help, then you might want to have that conversation with your doctor. So cholesterol can also, I also test cholesterol just to be, it's low on the hierarchy of what really impacts a cardiovascular event. Like what's more important really are history of MI or myocardial infarction. And then we look at lifestyle factors. And then we look at hypertension, which is high blood pressure. Those are higher on the scale of risk than cholesterol, but cholesterol still matters. So we look at that. But I would say 99% of the time I can treat cholesterol. I help women lower their cholesterol without statins. We just always do that. Unless it's like really, really like quite advanced and we're having trouble. The pills are costly. The natural medicine is costly too. So there's that factor, which is challenging. But what I do also is a lot of functional medicine testing. So I look at cortisol, I look at blood sugar. If we have abnormal blood sugar or high blood sugar, it's going to be harder to manage our symptoms, and we're also more likely to gain weight and things like that. So I look at blood sugar. I'll look at neurotransmitters. If I'm having trouble treating and getting like the symptom of any moody, symptoms or irritability or difficulty sleeping, if I'm having trouble treating that, I'll test the neurotransmitters because that can be helpful. And I'm looking at thyroid, including thyroid hormone, looking at hormones, including thyroid, and gut health. Gut health is huge because like I said, there's this amazing intersection between gut, brain, and gut-brain hormones. So I look at that a lot. So how are we going to transition being strong, wise, looking at the beauty of the changes as opposed to letting the symptoms kind of freeze us in our tracks. And we want to be strong through this time. We can really we've had so much experience we can share with the world now. At this point, we're ready to make change in the world. So here are the treatments that I think are most helpful. So I'm a naturopathic doctor, so I do naturopathic care. And I'll explain what that includes for menopause or perimenopause and postmenopause. Natural medicine management of menopause is quite effective. And then I usually counseling and social support is huge. So I wrote that down, and then I'll talk about hormone therapy. So my favorite kind of naturopathic care, targeted nutrient therapy. So depending on the symptoms that someone comes in with, and I had that whole list of symptoms, right? So I look at all the symptoms and I try to figure out, okay, what do I think is what's really most bothersome to someone? And working on helping them with those symptoms that are most bothersome to them. What brings them in the office? Women with hot flashes they're not always bothered by it, but a lot of times they are, especially if it's waking them up at night. So, I mean, my vision is very skewed because I work in a menopause clinic, so women are coming in being bothered by it, but a lot of women, kind of general public, like, it's okay, they can deal with it, it's not so bad, but some women, it's very severe. Botanical therapy, I'm gonna give you a list of my favorite botanicals. Including what I do sometimes is like these biphasic estrogenic and progestogenic like herbs. And I kind of mimic like what a cycle would do with herbs. Amino acid therapy. Those are things like 5-HTP or dopamine, some form of dopamine, or tryptophan or tyrosine. I use amino acids a lot to help women focus, feel calm, feel content. So SSRIs or antidepressants are also used in perimenopause to treat symptoms. But we can also get really far with amino acid therapy because it's like using the precursor to what we're trying to do with the medication. So I get really far with those, and I love amino acid therapy. Lifestyle is huge, so working on sleep support and exercise, if we get away with less at this time. Detox, working on gut, adrenal, thyroid health. Sometimes homeopathic treatment can be really helpful. I'm not a constitutional homeopathic prescriber. I will give homeopathy out, but when you get somebody who's really good at that, and there are some people here in this community I know, it can be amazing. It can really just shift, especially like the emotional aspect of what they're working on, and trying to get to that, feel less like they're stuck in a corner and more like they can move around the room. That's what I experience with homeopathy. It can be really powerful. Bioidentical hormone therapy, yes. Yeah. Of homeopathy. So homeopathy it's very different than the biomedical model. It's more in like a physics, kind of nanophysics level. I think about it like that. Like the dosing of homeopathy is on the level of the way our cells are communicating with each other, that very small signaling that's occurring. It's very, very minute doses that is given to the body to help encourage function as opposed to overpower or suppress anything. It's like, here's a little boost, here's a little nudge in the right direction, and the body gets a hint of that nudge and kind of takes over from there. So it's helping the body move in a direction without overpowering function. That's how I think about homeopathy. So it's very much given, we prescribe based on very interesting symptoms like fears. And it sounds out there, and it is, but people are really good at it, and it's amazing. You can see it work on kiddos, you can see it work on animals. So there's more to it than the placebo effect, but it does get that reputation like placebo effect. It gets that reputation. And I'm not a skilled, I will admit that, I'm not a skilled constitutional homeopath, but we get trained in naturopathic school in the modalities for 2 years. We get training on it. And it can just shift things. Like, it's amazing on the emotional level. I love it. So I think it's great to have someone do your remedy, give you remedy. But it can really help. Bioidentical hormone therapy and acupuncture, Chinese medicine, can be also very helpful. Okay, so, oh wait, I went backwards, sorry. All right, so here's some of my favorite herbs. So I love botanicals. Botanicals, so if you think about pharmaceuticals, a lot of pharmaceuticals are built off of what we discover in botanical medicine. We'll take a constituent from something that we discover, like aspirin was that, for example. We took a constituent from a botanical that we found in nature to work well as an anti-inflammatory, and we took that out and we created a medicine out of it. But it left all the rest of the plant, the protective elements of the plant aside, and took one constituent that we discovered in science would be helpful, and we use it in now as like an aspirin alone. The thing about botanicals that are nice is it can be very effective, but also very gentle at the same time. Gentle and effective. So protective and effective, which I love. At the same time, we have to be careful because a lot of botanicals are contraindicated with medications, and a lot of them are contraindicated based on history. So you to make sure it's not affecting medication, because medication can be processed slower in the body or faster based on a botanical. St. John's wort is a great example. Doctors are very hesitant to prescribe St. John's wort because it competes in our liver for the detox pathway. Same detox pathway that a lot of medicines get detox through. So it's like considered like a funnel effect. So you have more things trying to get through a narrow opening. And if you have a drug and St. John wort being trying to detox through the body, be processed through the body at the same time, it's going to slow down the process of that medication. We'll build up more medication in our system. It can be not good. So we have to be careful about interaction. So you have to know how to work with medications. Black cohosh is lovely, and I've given you indications here. So when women come in, they're having joint pain, which can come as well, and they're having hot flashes, profuse sweating, achiness. Black cohosh can be a great first thing to try, and a lot of menopause-specific combinations like herbal blends will have black cohosh in it. Here I give you the dosage, and I also say here, you know, if there's a depression element, to consider St. John's wort in addition. So that might be something to try, but I wouldn't try it with somebody who has liver disease or who's a heavy alcohol user at all. I would not try black cohosh because I've seen liver enzymes go up. Liver enzymes, when they go up, it means there's something going on with the liver. The liver is not happy. We don't want to create a situation of having like fatty liver, anything like that. So you have to be careful there. Siberian rhubarb can be lovely for anxiety and hot flashes together. And that's the dosage that I've seen effective. So often what I'll do is I'll try one thing. If that's not helpful, we try the next thing. And I usually have to give like 4 to 6 weeks to really see if it's working. So you have to be a little bit more patient with botanicals. They can work really quickly though. Maca can be lovely for libido. So when I think about somebody's libido is starting to tank and they want that kind of boost back, they're also having hot flashes, anxiety, depression, bone density. I'll think about maca, but maca, you definitely want, and we have great resources here at Coastal for to coach you through like good brands, and I can also give you recommendations too. But maca, and this is all education, under the umbrella of education. I'm not your doctor, so I'm not prescribing anything for you. By giving this information, this is all education, but you definitely want to ask your doctor, right, to make sure it's safe for you. But maca can be really quite helpful, although it can also make people feel more anxious. So it's like some medications, you're giving it for something, but it can have the opposite effect that we don't want. So I've seen maca do that too. Valerian, oh, I love valerian. It's so helpful for sleep. Oh my gosh, somebody's having trouble sleeping and they're anxious, valerian, love it, at night, giving it at night. Great for hot flashes, night sweats, insomnia, high blood pressure too. So that's why herbs are wonderful, because they're having multiple, they're impacting multiple different pathways. Studying mechanisms of herbs is like the hardest thing in our testing. It was like homeopathy and botanicals and pharmaceuticals, knowing all those in the clinical exams. It was because botanicals, they have so many actions. But there's the dosing that's been effective, seen effective. Vitex is great for somebody who's having irregular bleeding. And irregular bleeding is part of our normal as we transition, but especially if there's a lot of PMS and heavy bleeding, I'll give Vitex. And some women have some nausea and GI symptoms with that, so that's just why I put it up there. Wild yam can be a progestogenic herb, so you take it the second half of the cycle, and it can make us feel calmer, sleep more, feel less irritable. And we have great resources here. Joel, it's Joel, right? Joel is amazing. I walked into this pharmacy, by the way, and we have amazing pharmacies on the West Coast. And I'm from California originally, so I know a lot of them there, and Portland's like a hub for natural medicine. And I walked in here and I'm like, oh my gosh, this is one of my favorites I've ever been, seriously. It's just like, yeah, it's very dialed in, it's like how I like things. Like, we get the best of the best in here. We don't have to have so much, it's like great. It's like, we have everything we need here, and a great pharmacy. We're so blessed to have you guys here. I'm so glad. Yeah. So Pycnogenol is an amazing antioxidant. I use Pycnogenol with pelvic pain. I use it for endometriosis. It's an amazing antioxidant. It's helpful for hot flashes, insomnia, hypertension, high blood pressure, anxiety, depression, sexual dysfunction, memory, and that's the dosage. So those are some of my favorites. I hope that's helpful for you to like a place to start. You definitely want to ask your doctor, make sure there's no interactions, but you guys came here, you came all the way. I wanted you to have some really good pearls. Okay, so hormone therapy, let's talk about this, and then I can take questions. So, like I said, not all women are going to require hormone therapy. About 70 to 80% of women remain healthy and benefit from high-level nutrition, lifestyle management, maybe some botanicals, and they transition gracefully through this time. And like the healthier, honestly, we just have our threshold is lower. So you have to think about everything's going to impact you more. You can't push it multiple nights after multiple nights. 12 o'clock p.m. or 12 o'clock a.m. is not a good bedtime. It's just not. So you have to re-examine, like really truly the things that, and then exercise is huge too. But it is indicated, hormone therapy. So it's indicated, especially doctors will be interested in having a conversation with you if you have, and this is my little tip, hot flashes that are bothersome and osteoporosis. So if you get that DEXA, that bone density scan ordered to see where you're at, and if you have that going on in family history and you have hot flashes, night sweats, there's gonna be a conversation that can happen with your doctor. I mean, because those are what that's like the indication for prescribing hormone therapy. And I'm gonna give you some tips on what to ask for. Okay, because I want you to feel safe if you're gonna go there, okay? And I want you to be safe. So, other hormone therapy indications. Wait, I just want to go back really quickly. Urinary symptoms and sexual dysfunction. So hormone therapy might also be prescribed in those cases. Estrogen I see work way better, honestly, than testosterone. So like if somebody's really amped to give you testosterone, be a little bit, I think testosterone, there's a place for it, but it's like not I often will put somebody, in Portland, Oregon, naturopaths can prescribe testosterone. Here, we do not prescribe. It's not under our scope. We're trained, it's frustrating, but we're trained to do it. I only do estrogen and progesterone here, but in Oregon, I've prescribed testosterone a fair bit of times, and I often will take women off of it. Like I'll put them on, take them off, because it's either not helpful, they don't like the side effect of any acne, irritability, hair loss that can come with testosterone, and often what I see over the course of time, like they'll be on testosterone, but I'm always checking their levels because I never want them to go too high. And our body just processes it differently over time. And often it gets too high and I have to pull them right off. It's like, oh, I don't want that. I don't need that. You know, we can get really far with estrogen. So estrogen alone can do a lot of what testosterone is doing for the body. So I love estrogen. Bioidentical estrogen is very helpful. So sexual dysfunction, that's where I want to talk about that. So don't rush to testosterone. Testosterone is not like, it's just not, there's so much other, honestly, maca works better than testosterone in my opinion. It works great. It can work really great. So if you have a high risk, this is an indication for hormone therapy. If somebody's going into menopause early, so if they're under 45 and they're going through menopause or they're perimenopause and they're really close to that menopause window, it is actually indicated to give hormone therapy because we have that much less cardiovascular and bone protective exposure to estrogen, the good stuff about estrogen in the body, and it's more indicated. If somebody's less than 40 and they're going through menopause, I'm going to give them hormone therapy because it is a preventative, helpful thing to do. And I'm doing more harm to somebody if I'm not giving them hormone therapy. So I think that's where a lot of non-menopause specific doctors, they're very shy. And I'm going to explain why they're shy with the treatment, but why to not be shy, because it's very protective. Again, like the risks for the osteoporosis are thin, small, sedentary women, poor diet, excess alcohol. If there is a history of cardiovascular disease, we want to consider giving hormone therapy because you're at more risk with that low estrogen. So postmenopausal, we're at higher risk. So it's protective, it's cardiovascularly protective if it's given within a certain window. So you don't want to go too far out from menopause before talking to your doctor about it if you want to have a conversation. And then long exposures to corticosteroids or other estrogen depleting medications, a family history of Alzheimer's. So that's really interesting. The research shows that hormone therapy, if it's given too late, can hasten dementia or Alzheimer's if it's going to happen. But if it's given within a certain window, it can be protective. So it's very interesting. So if there's a family history, and I hear that in someone's history, and I hear family history of Alzheimer's, I'm going to be considering, I'm going to be considering this for them. When it's contraindicated, and there are some exceptions, but breast, uterine, ovarian cancer history. although there are some exceptions. And a lot of doctors will still be okay to treat vaginally, like with low dose hormone, even with a history of breast cancer. So like our very, very advanced MDs in Portland, Oregon, and I have yet to get to know the oncology docs here, but I'm going to have more conversations soon. They're okay. You know, we do a little bit vaginally, and it's okay even if they're on a ongoing chemo. History of thromboembolic, so history of any sort of clotting history. It is contraindicated to give oral estrogen. There are some exceptions made for through the skin. When we take estrogen orally, it impacts the way our clotting factors change the liver. Anything that goes through the mouth has to get processed through the liver. When we go through the skin, we do what's called a first bypass. So we can use that hormone or use whatever goes through the skin without going through the liver first and impacting the clotting factors. So transdermal through the skin is much safer for people with a cardiovascular history. And it's much safer in general, in my opinion. Liver and gallbladder disease and smoking, contraindicated. So in hormone therapy, what we're talking about are the types and how it's given and the dosing and the ratio. So there's the estrogen, bioidentical and non-bioidentical. Explain what that means. Oral, topical, vaginal are the routes. Progestogen, I'm going to use that term as like a broad umbrella term. Bioidentical, non-bioidentical, oral, and topical. That's typically how it's given. Both estrogen and progesterone. If you have a uterus, you have to take estrogen and progesterone in the right dose together, because if it's not given in the right dose together, so remember when I said estrogen is like the building blocks? If we take too much estrogen and we're not getting enough progesterone, we can create a situation where we have a thickened uterine lining, and that can put us at risk for uterine cancer. So we absolutely you have to have somebody who knows what they're doing and that is prescribing safely if they're going to put you on hormone therapy. Okay, so this is where the doctors get really shy, who don't know the more recent research. This is the reason. I'm going to talk to you about the Women's Health Initiative and what happened in that study. This is a huge, huge study that was a long period of time. We looked at almost 70,000 women. It happened between 1991 and 2010. And there were many subsequent studies that took some data from that big study and re-examined it. And that's where we really learned a lot more. But if a doctor went to school in this period of time and they were trained only on the Women's Health Initiative study, they can be very hesitant to want to even talk about hormone therapy, because I'll explain why. But the women that were participants were between the ages of 50 to 79. So what do you, like, just hearing that age range, what do you think right away? Too late. And that is what we learned later on in doing subsequent analyses of this data, is that when we separated out women who were younger from women who were older in that study, we saw completely different results. So by grouping all these women together, if we have more women who are 5 to 10 years beyond menopause, they had higher risks for things. And we took all that data and just put it together and just said, blanket statement, risky, stop, don't prescribe this. But we missed out on a lot of helpful things about hormone therapy. So it also involved observational study looking at lifestyle health and risk factors, and then some community prevention studies in the Women's Health Initiative. But what this is basically like, this was the hormone piece of the trial. We looked at two groups. Women with a uterus were given estrogen and progestin. Both were non-bioidentical. Okay, so let me explain what bioidentical means. So bioidentical it's still a hormone that's made in the lab, but it's derived from natural substances. So often we're using soy is one of the main totally safe, very safe derivative. But also the main piece about bioidentical hormone therapy is that the molecule looks exactly like the body's making it itself. Non-bioidentical is a molecule that acts on the receptors. It acts like estrogen, acts like progesterone, but it looks different and it has an entirely different risk profile. Does that make sense? So bioidentical, non-bioidentical, still made in a lab, still made by could be made by a pharmaceutical company, right? But can also be compounded. We have lots of ways of delivering. But they have very different risk profiles, very different. So this study, WHI, looked at only non-bioidentical hormone therapy. And the way that it was given was orally, both progestogen and estrogen. The estrogen is actually equine estrogen, so horse, many different estrogen types from horse urine, which we know is much riskier now than giving bioidentical hormone estrogen. So what we saw in this group that took oral estrogen and progesterone, there was increased risk of heart attack, increased risk of stroke, increased risk of blood clots, increased risk of breast cancer, reduced risk of colorectal cancer, and fewer fractures. Those are the only two benefits. Estrogen only, interesting, no risk for heart attack or breast cancer. The breast cancer was kind of like iffy, but really they didn't see an increased risk. There was still an increased risk of stroke and increased risk of blood clots, no difference in the colorectal cancer and fewer fractures with estrogen alone. So what does that tell you right away? What? Estrogen can be helpful, and I'm going to explain why we think that this group still had increased risk of stroke and increased risk of blood clots. One is that it went through the mouth. One is that it was non-bioidentical hormone. One is that this group that actually was studying the estrogen alone had other risk factors. So I'll explain that too. So they weren't identical groups. As a researcher, this stuff is so important to know because it makes a huge difference. And hormone therapy can really be helpful, super helpful. So we talked about that age was like way too broad, way too far into the postmenopausal period. The estrogen alone group had higher body mass index, more years of prior exposure to hormone therapy. They actually had more women in that group with more hormone therapy before the study even started. So that's going to completely change that's like a huge confounder. That's not how we do research. And estrogen, so more than the estrogen progestin participants. So our interpretation needs to be cautious. And then we only use non-bioidentical forms, as I explained, orally. And we know that oral estrogen in any form, even like birth control, orally puts us at risk for blood clots, okay, and stroke, and younger women too. We get past that. If women have migraines, if they have a history of blood clots, and they're at any age, it's risky to give estrogen orally. It is. So here are some debates that emerged from the research, and then since then, what we've seen, and I'm going to explain kind of like what I have gathered from the research since then. Women's Health Initiative, when we took a subsection of those women, we took 50 to 59-year-old women taking hormone therapy, and we looked at them for that 10 year, who were taking hormone therapy for the 10 years directly after they started it, within that 10-year period from menopause. They saw no increased risk for cardiovascular disease, stroke, or blood clots, and that's even with oral estrogen, non-bioidentical. So very much a timing issue when we separated them out, the ages. So that was really interesting. Since then, the Women's International Study of Long-Duration Estrogen and Progestin after Menopause, the WISDOM study, women had increased risk of cardiovascular disease and stroke, blood clots when the treatment began after 10 years after menopause. So these are the big two things that we learned after the main results came out from Women's Health Initiative that made us say, aha, there is a timing hypothesis here to consider, and that's really important. Timing, really important when you're prescribing therapy. And I conservatively say any hormone therapy, because we do have research on bioidentical hormone therapy. It looks like there's really no increased risk, but because these studies are much smaller and fewer, I still want there to be caution. Okay, so I'm not an absolute person. It's not absolute. Even the big studies are not absolute. The risk is statistically small though, and this is non-bioidentical hormone therapy. 1 in about 10,000, it appears to be linked with the duration of greater than 5 years of use of non-bioidentical hormone therapy. But we are thinking there's a type of therapy that makes a difference too. And then research also suggests that about 34% of breast cancers could be avoided by making lifestyle changes. Absolutely. There's so much we know in the research now. I would say most of the cancer research that's done on women is done on breast cancer. We see so much done on breast cancer. My best friend actually passed away from brain cancer a year and a half ago. It was horrible. She went through it for 9 years. I was doing every bit of research I could, everything I found, most everything I found. There was some element of, we've studied breast cancer for this. We've studied breast cancer for how much alcohol you should drink or not drink, how much exercise you should have or not have, how, what herbs or nutrition is helpful for, and it's like, we looked at breast cancer. Breast cancer, there's a ton of research, and it really makes a difference. Lifestyle really makes a difference in reducing our risk of breast cancer. So I have actually a write-up, if you want to read, this is what I wrote for her. I wrote this, I went and did the research, I wrote this for her, I made it into a blog post, and it's on a Women's Time where I used to work, a Women's Time website. And if you go to that website and you look back to, I wrote it and published it in 2015, but it could be updated. But it's still so pertinent. It's like, here's the dietary recommendations, here are the herbs, here's the nutrition, here's the exercise, here's the recommendation on alcohol. It's all in there, so it's a helpful document. And let me know, I'm happy to email it to you too. All about education. Okay, so the other debate is, there seems to be an increased risk of venous DVTs with oral hormone therapy, but this increases with age and body weight, unhealthy body weight, because body weight alone is not an indicator of health. It's not just body weight, it's like unhealthy body weight, right? Because we can be strong and that's our size, that's our body habitus, and that's good and healthy. But it's like when we're gaining weight in the areas that we know are more risky. So, and it may be more associated with the progestogen type and the oral aspect. Observational studies suggest that it may not be associated with transdermal hormone therapy. So from the data now, as we've seen it, and we've seen a lot of smaller studies, I didn't put everything in here, but basically this is what I present to my women based on the research, and I get trained every year on the updates, but basically there's a timing hypothesis. So the initiation of hormone therapy is ideal within about 3 to 5 years, if we can get in within 3 to 5 years, but no greater than 10 postmenopausal. We do see an increased risk actually starting, it would be contraindicated. I just don't start hormone therapy after 10 years postmenopausal because of the cardiovascular risk, regardless of using it through the skin or not. And that has to do with because as estrogen depletes, those arteries are becoming stiffer, frailer, thinner inside our body. If we have any plaques in there at all, and that can be for many reasons, we're much more likely to chip away at those plaques with the blood flow, especially if there's hypertension or high blood flow. We're more likely to chip away those plaques and loosen them and create a clot. Okay, so with those stiff arteries, if we have compliant arteries, flexible, kind of thicker walls, because estrogen feeds that can create flexible arteries, we're less likely to have cardiovascular disease risk. That's part of the timing hypothesis. The route matters. Transdermal estrogen is safer, but you do have to take oral progesterone. So progesterone can be given as a topical cream for symptom management, but if we're giving estrogen, we have to give oral progesterone because that's the only way we know it's been studied to protect the uterus. So from that thickened lining, that's the only way we've seen it studied for protecting. So we have to give oral estrogen, or oral progesterone, but we can give it with the patch. So you take two things, but if you don't have a uterus, you can go with estrogen alone. But progesterone does a lot of things besides just protect the uterus, right? It's very calming, it helps us sleep. I mean, I have women begging me for progesterone, like, increase my progesterone, please. I'm sleeping so much better. I finally don't feel anxious. It can be really nice. So, and then, other people, I would say rarely do women not tolerate it. The bioidentical is lovely. It can be really lovely. Like I said, it's what our body has created. Our body's used to it, the same molecule when it's bioidentical. And the type matters. So I've been talking about that a lot, but so far we haven't seen increased risk for I say that with caution. I say that with the caveat that we have small studies, but so far so good. So I still say, look, there's about a 1% increased risk. If you're in a higher category of risk, you've had a history, you have a first degree relative with a history, you have a risky lifestyle. For breast cancer, I always get a mammogram before I prescribe any hormone therapy. Make sure we're not dealing with anything there right now. But so far, Bioidentical's looking good. It's looking much better in terms of safety. Still, I say after 5 years, there could be a risk. So we got to work really hard if we're going to stay on the hormone on decreasing your lifestyle risk, through lifestyle, working on all the things that are supportive of breast health, healthy breasts. Cardiovascular disease is looking much better with bioidentical hormone therapy, especially when estrogen is used topically. And it seems like with both breast cancer and cardiovascular risk, it has more to do with the progestogen type, bioidentical versus non, than it has to do with the estrogen alone. So a lot of women are like, it's about the estrogen and breast cancer. It actually looks like there's more risk with it has more to do with the progestin type, which is interesting. I can talk about this stuff all day long. I love it. I hope I haven't bored you. No, really, I just was wanting to give some really good information. Like if you were in my office, we would still be talking about it. So I thought, they're coming out here. They're like braving that this is time of our life. I was saying to Kim, it's like, it's not easy to kind of face that this is happening, and it's like, it's one thing when you come into your doctor's office and you feel like this safe place and you can kind of draw back the curtain and say like, this is not what it happened too fast. And we were talking about how like readers, you like all of a sudden need readers and it's like, oh, that just happened way too fast. No matter how healthy you are, it's still going to happen, it doesn't like, and none of us are perfect. So I just wanted to give you some good information today and be a resource to you. So, and I'm happy to have conversations with docs. I get on the phone all the time and have great relationships with gynecologists in Portland, Oregon, and developing those relationships here. I was going to tell you about vaginal estrogen. Let me tell you about that because happy vaginas. Okay, vaginal estrogen can be so safe. And it can be low dose, and it can change everything. I give it all the time. No, vaginal estrogen, and let me just tell you right now, your gynecologist is going to be more likely to prescribe something called estrase. It's going to be more likely to prescribe something like that. It's very expensive, very expensive. If they're open to compounding, we can get it so much less expensive, and I think that the safety profile is much better because I can get it in a very hypoallergenic base. Who wants to put a bunch of crap in their vagina? No, not me. But I do want some estrogen, I'm going to want it when the time comes and be like, give me my estrogen. No, but if you have if it's not contraindicated for you, and there are some contraindications, but they're very few with vaginal estrogen because we dose it really low. We dose it so low that we don't even need progesterone to balance out that vaginal. And it can make a difference, a real big difference in decreasing our risk for infection, decreasing our risk for vaginal dryness, increasing even libido a little bit, helping kind of plump up the tissues down there. Blood flow, increases blood flow. So I love compounded estriol. Estriol is E3. I love giving that. We can give E2 too. There are 3 different types of estrogen. E3 is the safest. Often when I'm doing a patch for total body, I'm giving E2 because it's very effective. The E3 vaginally is I do that because there are more receptors for E3 down there and it stays more local. It still goes systemic, but it stays more local and it's amazing. I'm oh, I can have a sex life again? Thank you very much. I thought I had to it was all done. No, it's not. It doesn't have to be. And estriol. Yeah, so there's a loading dose period every night for 2 weeks. It's typically how it's given vaginally a night. And then you go to a twice a week or 3 times a week, depending on your need. But also has to be prescribed very carefully because if you get too high and if you're overdoing it down there, you're putting yourself at risk for endometrial hyperplasia thickening because it still can be too much. You have to balance that out with progesterone if it goes too high. So, you don't want to overdo it. Just take it exactly as prescribed. But ask for some options from your doctor because estrase is wacky expensive and I am I'm so sick of the freaking high cost of medications. It's making me feel mad. You see the back end of things and how much they cost, and like you see where the huge ripoffs happen, where people are making lots of money, and it's unfair. And I think that's like one of those medications. You get like a vulnerable population, and this is helpful. It's very helpful to have some vaginal estrogen, and it's just that cost. You can make a profit, so why not? Makes me mad. But there can be other ways to do it, and environmentally medicine speaking, I love environmental medicine. I'm all about decreasing our toxicity overall. The last thing I want to put is a bunch of petroleum products on you, So, especially in your vagina. Anyway, compounding is a lovely option because we can get these bases that are super hyperallergenic, and it's like, that's what I want. That's what I want. Oh, I give that to you. Yeah, exactly. Yeah, there's so many options here. Like we can do coconut oil as the base, and it's just a capsule, and it's still, you get a little discharge because it's, it's a little bit goopy, but the hormone gets in there, the skin absorbs it. You're using coconut oil. It's so lovely, and like a veggie cap that dissolves. And you might use a panty liner the next morning, but you get to the point where you're at 2 times a week only. You do that after, if you're gonna have sex or whatever, you do that after, right before you go to bed. You're lying down, so you're not discharging it in the nighttime. You're absorbing the hormone. And yeah, it can be done really lovely, yeah.
Can you speak a little bit about how you can figure out the process of honing in on what you're forming, what you're using, that you
Progesterone, yeah. So,
how do you figure it out?
Yeah. Thank you. Yeah, that's a great point. So I get a lot of baseline testing before I prescribe hormone therapy because I'm going to make sure I have a really safe candidate. I would say about 50 to 60% of my patients in Oregon, I think I've reached 1,000 at least women. I've treated a lot. I have like about half on bioidenticals. So I do a lot of baseline testing, make sure you're a good candidate. And then as long as we get everything looking good and you feel comfortable and I feel comfortable, I start on, and this is how with everything with me, because I'm a naturopath, so I'm trained this way, smallest dose for maximum effectiveness. We start low, we increase if needed. So I start with a low dose of estrogen and the lowest dose possible with the progesterone, while still being protective. So the lowest dose orally that I know of in the research is 100 milligrams orally progesterone. But your doctor has to decide these things, this isn't something you can prescribe yourself. And then I have women come back 4 to 6 weeks. How you doing? What are the symptoms like? How have things changed? Are you tolerating this well? What have you noticed? So you take good notes if you're going on this, doing this. And we might increase the dose. Let's say you have osteopenia or osteoporosis. You're going to likely want to be on a higher dose because it's more bone protective. So it totally depends on you. But sometimes it's like women really like that they're on a low dose, they feel more comfortable, and it's taking care of their symptoms. And it's really helping them feel supported. It can be really supportive and like cardiovascularly supportive, helpful. So we don't need to have so much fear around hormone therapy. We need to have smarts. We just need to do it conservatively, least dose, for maximum effective, in the right population, and it can be helpful. And it doesn't always need to happen. And I've had patients who come in very complicated, and I've literally given like one thing and it changed their life. It's usually not the case, but I have one patient, and I know it's like soy. It's like, oh, because of the history of soy and being nervous about it. Soy is safe. Soy is very safe. Like the research that was contra soy, as long as we're talking about GMO, GMO-free soy here in like in a food base, not in a capsule, not super high dose, but in a capsule food base, safe, no problem. And I have literally given like soy because it's a phytoestrogen. So meaning like it's a plant, we use that, right, as a derivative for our bioidenticals. So I've given just a little bit more soy in the diet as a treatment for somebody who's very risky. I couldn't give her hormone therapy. And so I have so many tricks on my sleeve. And that like made a huge difference for her. She was sleeping. She didn't have hot flashes, night sweats. She was very sensitive. So you can you absolutely don't, it's not like you have to have hormone therapy. And a lot of doctors will say, oh, not going there, you know, but they're also maybe not menopause specific trained. So you definitely, I don't know all the doctors around here yet, and hopefully you feel like you have a really good relationship with your doctor and you can have conversations with them. The best thing a doctor can do is make you feel empowered, right? Not like, oh, I know everything and you've been living with your body, this, you know, they haven't. And you want to go in there and say, like, this is what I really, you know, this is what I really like to do. And you want to feel heard and you want to feel validated and have that kind of collaborative relationship with your doctor. That's what I hope for you. And I hope that this information is going to help you feel empowered. Yeah.
I'd love to hear your theory.
I think it's environment. I think there's a huge environmental impact. We're dealing with a time when we are exposed to the most ridiculous number of chemicals without even really knowing how those are affecting us, but they absolutely are. I'm going to speak in April at a big symposium. It's called the Environmental Health Symposium, and it's experts from all over the world talking about how the environment is impacting us. And my topic is on what we call endocrine disruptors or hormone disruptors and infertility. And it gives me chills because we're seeing a lot more infertility. We're especially seeing it in our men. We see like normal sperm counts have declined, where like the normal range has decreased quite a bit. It used to be here 10 years ago, now it's here. We see things like plastics, plastics. We absolutely know that plastics that we're finding, microplastics in our salts, we're finding microplastics in things like mac and cheese, which kids eat all the time. And it's in the New York Times articles, like, not just scholarly journals. We're seeing that impacting our boys when they're not developing their testes, like normal. We see a lot in boys right now. Boys, I feel like, are much, girls too, but I think the boys, we're just seeing a lot in our male health. So, but I'm talking on that topic of infertility, and so environmental medicine is a big passion of mine, and I think we're just exposed to craziness right now. And it's not, you don't want to feel unsafe in the world, but you just want to be educated and know how to decrease your risk. We're not going to decrease our risk entirely. And there's certain things we might want to live with, but knowing what we can do to lower our risk. So, and we're seeing that. I think it's huge. It's in Arizona, in Phoenix. Yeah, it's for healthcare providers. I thought it was for general public. It should be, I think. But I'll probably post some like tidbits of my talk online. So if you follow me, I will post. Yeah. Ooh. Oh my gosh, huge. Okay, yeah. So. Oh, I wish I had a big map, but basically, our hormones, like where we start with, we need cholesterol. We need to eat cholesterol. We need to have cholesterol in our diet because cholesterol is what creates our hormones. Cholesterol is what creates our adrenal hormones too. It's like the backbone of our hormones. So depending on our level of stress, over time, depending on our lifestyle choices, our sleep choices, our dietary choices, we can be kind of pushing that high cortisol level for way too long. And it's like the same with sugar. We get too much sugar in the bloodstream and our insulin and our receptors become dull. They just get tired. They stop responding. It's the same thing with cortisol. We have too much cortisol in our system for too long. We're running away from the tiger all the time. We feel like we're running a race all the time. We're not getting into that rest and digest, relaxed state enough. And that pushing, it's less about less cortisol being outputted and more about these receptors in our body not responding as well over time. Like we get receptor fatigue almost. Like the receptors start shutting down, in fact. It's the same with insulin resistance. It's the same with high blood sugar. So it's a term that's been used more in the past. I feel like adrenal fatigue. Now we're calling it more like and HPA axis dysfunction. H, hypothalamus, P, pituitary, A, adrenals. The adrenals sit on top of the kidneys, and they put out that cortisol. So we have too much pumping out all the time. Those receptors get fatigued, and we have, like I said, a lower threshold over our lifetime, or over this part of our lifetime. The threshold just gets, it's like, we just can't push it as much as when we were younger. And we've had more time exposed, so our bodies are a little more tired. We have to take it easy a bit more. It's also progesterone. It's really like progesterone is calming. It's very calming. So we have less eggs, so we're not ovulating, so that we're not producing the progesterone. We don't have that corpus luteum to produce the progesterone. So the anxiety, we start feeling it, and the insomnia also comes with that. It's because we don't have that calming progesterogenic herb. You know, and that's why I said wild yam can be nice in that second half of that cycle. Sometimes you start there. If it's not contraindicated, it's not interaction with a medication, trying it in the second half of the cycle, so even that's helpful. But there are a lot of herbs that I just gave you a handful, but there are a lot of herbs. I'll make blends, tincture blends with lots of what I call nervines, which are nerve relaxing herbs. I love them. They're so lovely. Like, they can really just, that's all I needed, which is a little, botanical love. Botanicals can be so helpful. So. Yeah. That's a really good point. So teas that you buy can be helpful, in like a package. We have great teas here, but when we're actually looking for really strong therapeutic dose, tinctures or dried herbs that are actually made into like a tea that you make, that you concoct from the dried herb, can be much more powerful. So, but sleepy time tea can be enough for people too. I mean, chamomile actually really works too. So, don't try things with an open mind. I think like when I went into naturopathic medical school, I didn't even give herbs enough credit. I did not give herbs enough credit. I did not give natural medicine enough credit, even though I was going into that field and I had healed my body through that in multiple ways. But it's like through my study and through seeing how people have done over time, see so much power in those plants. So, and just a little bit can be enough too. Sometimes we microdose them too. Sometimes we just give a little bit, because it's like that idea. You don't want to overpower function. Thank you for coming. But you want to give enough so the body responds and then can kind of do what it needs to do on its own. And yeah, of course. Yes.
If you're on a hormone replacement,
Yeah.
not by
Yeah.
Can that be harmful too? Because I'm thinking like if your estrogen is high one day, then you should be going higher.
Yeah, that's a good point. And it's a really good point actually, because as we're losing that progesterone, unless we're taking it, we're in an estrogen dominant state for a little while in perimenopause. And so can that be harmful? Can too much estrogen be harmful? Yeah, definitely. Yeah. And so having your, often like what I'll do sometimes for women, and not always, if I'm doing really low dose hormone, I'm not testing their hormones. But it might be on, non-bioidentical hormone therapy, or they have risk of having higher estrogen.Maybe they have a history of that. I'm going to test. I'll test like every 4 to 6 weeks. I'll spread it out to 3 months. I'll spread it out to 6 months. I'll just make sure we're not hitting a high. And if we're hitting a high, decreasing the level. And then maybe we're decreasing it and their symptoms start coming back, but then we're using some herbal medicine too. And you can do that safely. So yeah, it can be risky. And certainly we don't need above what we call above physiologic normal. So you have a normal reference range for any lab. We don't want to get above what's physiologically normal. It's not with low dose prescribing. It's really not, because our body actually makes way more than what I give topically, typically. Like when you're in your, what do we consider average 20 to 40-year-old menstruating woman, your own body's producing way more estrogen than I'm typically giving in a topical form. So the likelihood for it to go high like that isn't high. So that's why I say I look at the lowest effective dose, safest effective dose possible. And, but, you know, some doctors start higher. And I've taken women off of those high drugs. So I had a woman come in who was having really bad headaches. Her doctor had started on way too high estrogen. So I lowered her dose and she had great results and she actually really felt good on it. She did not feel good on too high. I've had a woman who responded. She was on too high a dose. She came in, she was experiencing vertigo and headaches and some swelling. Not good. I don't like that. So, you know, I don't want you to have adverse effects. It's very rare. But yeah, you're right. Yeah. And I think it's prudent to, you know, when I'm starting on the low dose, what I usually use is a very low dose minimum amount. I'm not usually testing unless there's a history that indicates. But if somebody wants to test, and part of what I do now is I test regularly no matter what. And especially if they want to test, I'm going to test. Like, really inexpensive. So why not? You know, I'll just keep an eye on it. And you can always ask for that. I want you to advocate for yourself. You know, ask for things. Doctors are more likely to do stuff when you ask. They might not choose to do it on their own. Thank you so much for coming. Any other questions? Yeah, thank you so much for coming. I hope this was helpful.